Dr. Kasper.
Okay, so I wanted to add to today one additional discussion point, which is an unusual problem you may run into that is causing significant anxiety in most of us, which is if you encounter one of these aneurysms during pregnancy. Can you see my screen?
Yes.
Okay. So, second. Nothing to disclose other than the institutions I'm working in. So why this presentation? I think there's a significant knowledge gap for most of us when we deal with a routine situation of an aneurysm and we put it in an unusual situation like encountering a patient who has a second medical problem. And in this case, it's not really a medical problem. It's a natural condition of, a lot of the female population in the world are in their reproductive years and they may be in the middle of pregnancy when this encounters. So I want to give you a brief insight into why pregnancy surgery is special. You're dealing with two patients, not just one. I want to show you one case, and I want to give you some ideas on this. Background, while obstetric cases of maternal mortality have declined a lot, the non-obstetric causes of maternal morbidity and mortality have increased over the last 2 decades. Among the leading non-obstetric causes of maternal mortality and morbidity are neurosurgical problems, which is surprising to, I think, most of us. Subarachnoid hemorrhage and intracranial hemorrhage is the third most common cause for indirect death of pregnant women. It accounts for about 5% of maternal deaths. We have heard about anterior circulation aneurysms today from the experts, and they are the most frequent vascular pathology for structurally caused subarachnoid hemorrhage. We know that about 85% of intracranial aneurysms are saccular, so we want to talk about these briefly. Amongst the ruptured subarachnoid hemorrhages, aneurysmal ACOMs make up just less than half, a third to a half of those cases. In unruptured aneurysms that we see electively in our practice, we probably have 12 to 15% ACOM aneurysms in that patient population. But just to give you an idea, about 3% of pregnancies are associated with an aneurysm, which is a much higher number than I anticipated. But these are NIH data. So the big question is, how should we manage these patients if you come across it? The risk factors are the same. There's no difference compared to the general population of patients suffering from aneurysms, but it's a formidable challenge. There's some evidence that the incidence of subarachnoid hemorrhage increases during pregnancy, and this is probably related to the hormonal changes where release of pregnancy hormones softens your soft tissues in preparation of delivery. The statistics tell us spontaneous subarachnoid hemorrhage occurs in about 10 to 20 women per 100,000 pregnancies. So you may come across this in your practice. Differential diagnosis, if you have a spontaneous hemorrhage, is not different from what we usually do, trauma, aneurysm, AVMs, AV fistula, cavernoma. So if you have one of these patients, they should undergo the conventional workup. And then the question is, what's coming next? So I want to show you one of these patients that made me think about this. This was a 32-year-old woman, gravida 1, no previous deliveries at 29 weeks of pregnancy, who only had a history of hypertension, bipolar disease, depression, presented with worst headache of her life, was for 2 or 3 days just treated conservatively, then came into the ER, GCS 14, and at the outside hospital got a scan, was transferred just with the word head bleed. If you look at the right scan, typical subarachnoid hemorrhage of the basilar cisterns, Huntington's grade 1, Fisher grade 4. We did a CTA on arrival and it showed a 5 millimeter aneurysm, as you can see, with a left-sided neck originating just at the ACOM complex. And at that time, we just treated this with a right-sided EVD, took the patient to the OR, came in from the left side, did a pterional craniotomy and clipped this patient. She was lucky, she had no vasospasms. We'll talk about this in a sec. And the baby was delivered within the next 4 weeks. So I went away from this a little bit later as an early attending and thought about, did we do the right thing here? Did we just sort of do what we always do, or did we actually think about this, or did we not think about this as a team? Because I had a bunch of patients with similar problems in the next month. I really did start 10 years ago to dive into this in more detail. The problem is there are no prospective studies in neurosurgery on neurological outcomes for maternal or fetal well-being during pregnancy with many neurosurgical diseases, but certainly not for ruptured aneurysms. So the problem is here you need to make decisions with a significant lack in data. There's no great level 1 and level 2 evidence to really make good decisions. So a lot of it is based on case series. And going back to the literature, case series have not shown an obvious difference in outcomes, although there seems to be an increased rate of disease progression during pregnancy, slightly more seizures, and definitely a higher rate of cesarean sections. I think it is wise, even in the ruptured setting, not to say wait and watch and see what happens. And one should always call a multidisciplinary meeting, even in the middle of the night. This is not necessarily for you, although it's reassuring. I think it's for the patient and for the families to understand you looked into this not just from your single specialty perspective. So I call my colleagues in the middle of the night, neurosurgery, fetal maternal medicine, neonatology, and anesthesia, just to have input. And I can go back to the family and say, I discussed this with my colleagues. If it's a ruptured aneurysm, obviously waiting for weeks is not a good option, because we know that there's a high re-rupture rate in the first 24 hours as well as in the first 4 weeks. That leads to intrapartum complications. These aneurysms can bleed again. Intracranial hemorrhage may enlarge. There may be seizure, stroke, and death. So all of this is detrimental to the outcome. But what really needs to be considered in this setting? So I want to briefly go through 3 arguments. There's a risk of anesthesia to both the mother and the child from general anesthesia or epidural anesthesia. There's a risk to the mother, and obviously from a neurological status, and there's a risk to the baby, and there's a risk to us, especially in the United States. The legal risk in these settings should not be underestimated. In North America, the patients and families will look into this afterwards, no matter how stressed they are during the case. So regarding aneurysms in pregnancy, what is the anesthesia perspective? Well, this is a difficult case, right? The pathophysiology shows you the patient has weight gain, there's water retention, there's venous engorgement, there's edema of the airways, there's more reflux, there's decrease in hematocrit. So all of this makes this already a high-risk pregnancy, because positioning, possible induction of labor, problems of blood pressure fluctuations can make this significantly more difficult than in a routine elective case, non-pregnant, unruptured aneurysm. From a neurosurgical perspective, we are sort of in a difficult spot, because the use of diuretics is not really advocated in pregnancy. It decreases the plasma volume, it compromises perfusion to the placenta, which puts the fetus at risk. So maybe this is a case where hypertonic saline is better than mannitol. Nobody really knows this, but my gut feeling would say if you get away without, get away without, or use half the dose and open your basilar cisterns to have a wider exposure, which requires then less brain shrinkage. Conversely, the lack of brain relaxation makes intracranial surgery significantly more difficult in some cases. So do think about this a little bit. And obviously, if you have a ruptured problem intraoperatively, excessive blood loss with hypotension, hypovolemia are risk factors for possible harm to the fetus. Although we are usually lucky that during pregnancy, there's physiological hypovolemia and it's less of a problem in the mother. From a maternal fetal medicine perspective, there's some concern of stillbirth during brain surgery, which is unavoidable in my perspective. There's some risk for premature labor and delivery. And going back to my case, the risk for the baby survival at 29 weeks was estimated about 5%. That's a good number to quote to the family. Below 30 weeks, the risk is high. Above 30 weeks, the risk to the baby is not as high. And if you have an unruptured aneurysm, you can induce lung maturation with betamethasone. It's one aspect one should consider. The general consensus is in the ruptured setting, saving the mother is more important, and little reduction in fetal risk can be gained by delaying delivery. So I would not sit on these patients. The literature does not support this. The consensus in the literature is for ruptured aneurysms, you just follow routine protocols for subarachnoid hemorrhage, just like you do for non-pregnant patients. And for unruptured aneurysms, there really is no evidence that you have to treat. But my personal recommendation is, based on many other studies we did on neurosurgical patients in pregnancy, it may be smart to not go for a spontaneous delivery, recommend a C-section or forceps-assisted delivery under epidural anesthesia. This allows the intraop assessment of the neurological status of the mom and avoids pressure waves when the mom pushes. Summary, workup for spontaneous subarachnoid hemorrhage in pregnancy is not different from non-pregnant patients, and management of subarachnoid hemorrhage in pregnancy is not different from non-pregnant patients. We use triple H therapy, nimodipine, antiepileptics, and surgery, and there's a beautiful paper by Neil Kitchen from 2008 in JNNP that I really recommend all of you to read. It's in my slide deck. You can see the reference. Interesting outcomes show that pregnancy does not alter the mortality or the discharge destination for patients presenting with acute subarachnoid hemorrhage, and the mode of aneurysm treatment does not affect mortality or discharge destination either. So given the fact that we have a higher recanalization rate and a higher radiation exposure, if we try to do this with INR, I would personally still favor clipping versus INR coiling in these cases, but that is left up to you based on the patient's individual anatomy. These cases are a formidable challenge, and I think the best experienced hands in the house should take care of this. Outcome analysis. Patients with unruptured aneurysms who were clinically stable with aneurysms less than 7 millimeters and they remain so under observation can well be managed conservatively until pregnancy reaches term. Patients with ruptured aneurysms we talked about. One of the remaining questions I think we should address as a specialty is, are there any biomarkers that will predict the indications and need for surgery to make rupture more likely if we encounter one of these patients? Thank you very much.
Thank you. Very difficult situation when you encounter, especially in the ruptured aneurysm. I've had experience once, and it was close to term the pregnancy, so we were able to clip the aneurysm and then send the mother for C-section the following day. But add more additional stress in an already very stressful situation. And you pointed out very well that there are so many different considerations. Some of the medications that you can use, you might be limited, but it's important to know that at least for the rupture cases, the management should not be any different what we would do otherwise. Okay, well, if there are no other comments, I like really to thank my co-moderator and the panelists for another superb session. From the comments, all the participants have really appreciated, and I thank you also for your generous time on a Saturday. So we'll reconvene next month. We'll try to organize another one, and the topic will be cavernous malformation. So thank you.
Thank you. Thank you.
Thank you. Bye, everyone. Thank you
Bye-bye.
very much. Thank you. Bye, Giuseppe.
Bye.